of Trans-Kambin e-PLIF and have evolved to a new paradigm of PTLD. This is one of the few stories which I have seen over the last 20 years. In this patient, an operated patient of endoscopic transforaminal decompression surgery under local anesthesia, patient went back to Saudi Arabia, and this patient in 2014 ended up reporting to a major newspaper in India that his leaves are not sanctioned. The medical board has rejected his claims because there is no surgery being done on you in spite of the MRI which has been done and to prove. And there is no surgery which is possible through a pimple-like scar. And then finally we had to intervene and get his claims passed. So that is the story which is there, and many number of stories have happened with me. And the spine surgical revolution is endoscopic spine surgery. We all know that, and we do it painless, stitchless, and awake. And the renewed interest is more towards the Kambin's approach. That's why we all are here. Let me take you back in the timeline 2008, 2009, when I had started doing PTLD. With the initial jolts, I matured to a good outcome giving surgeon, and luckily it has worked in my hands and in many hands. And further, we went on to explore to newer possibilities, because as knowledge, skill, and technology evolves, extrapolation of the acquired confidence into other possible applications starts. Let me take you through this case of 71-year-old male in 9-month back pain and right lower limb radicular pain. He was elderly. The ODI was 86, which was there. And what you see is a lateral canal stenosis with facetal arthrosis, a facet tropism there, and a grade 1 listhesis. And this patient, we subjected him to under local anesthesia prone position, a transforaminal approach for endoscopy. And in that endoscopy, we could succeed with the cannula in place there. And this was the final thing, what you can see there with the decompressed traversing nerve root there, and all the endpoints of the decompression achieved under local anesthesia. And with this, we have already published the endpoints of decompression in lumbar transforaminal endoscopic surgery for all patients which we operate. We didn't stop in this patient at this point. Look at this, because he had mechanical pain, we were to go for fusion. We injected the medicines for the epidural anesthesia and went on ahead to do the preparation of the end plate. Look at the picture in picture here. See the wand moving. This is an Inspire gun, which was a borrowed instrument from one of my friends, and we had used it to prepare the disc space there. And we had placed the percutaneous guide pins for the screws also under regional anesthesia. And this is what is the Inspire, which helps us to prepare the end plate. But it took us nearly, with this, around 45 minutes to 1 hour to prepare the end plates only, and we could acquire a good prepared end plate. That is fine, but where is the bone graft firm? And we had an indigenous way of getting the bone graft, and I put a hollow mill-like thing which is into the iliac crest, as had been doing a lot of pelvic surgeries at some point of time, so knew the trajectory, went in there and harvested the bone graft. And this bone graft, what is harvested, is from 5 to 8 gram easily, what we harvest by multiple attempts. So these cylindrical cubes are what is we get, and we add with this hydroxyapatite bone graft substitute, and on that we then just put it into the cannula and pack the space with bone graft. And once that is done, the screw insertion is completed, and this is how the final picture of the patient. And this is the image of the patient with 4 screws inserted, and this is the entry point for your transforaminal. This is the percutaneous harvested bone graft, and this is 9-year follow-up of this patient now. And I've been very vocal about it. I presented it multiple places, including MISAPCon. In 2016, I went to international format and presented it there also. And finally ended up publishing in 2018 a 13-case series, but as a feasibility study. Mind you, as a feasibility study. It was 13 patients. The patient reported outcome measures were exuberantly good. Satisfaction was immense. Fusion achieved in all the patients, and the disc height loss was minimal, and there was no dysesthesia even transitory in this patient. But look at this conclusion. The conclusion that was that it is not appealing to be recommendable to general population in spite of it being low cost and negligible complications. Further research was needed with engineering tools for reducing the operating time. So what was the crux? The problem was this. The operating time average was 250 minutes for decompression and fusion both to be achieved, and the tolerance score was not which was happy about to be. That's why after nearly 27 cases, I stopped doing this procedure in that point of time. And the questions which remained unanswered at that point of time was, I didn't have better engineered tools. I couldn't expedite the procedure more. I didn't have biologics. I didn't have that cages at that point of time. I went on exploring further and doing good work in transforaminal surgery to evolve to stenosis surgery being decompressed under local anesthesia, even Cauda equina syndrome being decompressed with great outcomes under local anesthesia. And this is the latest which we have is something on calcified disc. This is a 79 patient series of long-term outcomes. This is a patient of a paraparetic L1-2 which is there, and we did transforaminal endoscopic decompression under local anesthesia. You see this is the excellent decompression, and the paraparetic patient recovers under local anesthesia. That's what is the outcome of the transforaminal surgeries. And we all have this interest in transforaminal approach because we all now know that it is least manipulative, and as you go more ventral it is least manipulative. And 2024 we have started revisiting and reinventing the things. Even I've seen the bipolar fluoroscopy being used by Professor Hamid, and I started doing under general anesthesia right now this procedure of Kambin single level fusion. And even my colleague Dr. Miran Dave, now he has done it under navigation under neuro monitoring. So we are evolving to safer parameters, and all this is because of one thing. We have kept the direct decompression aside and trying for the indirect decompression of the Trans-Kambin O-leaf, and the time is reduced by nearly 1/10 of what I used to take 10 years back. And that too in India we may be able to do it probably awake, aware and alert, and maybe without neuro monitoring in soon. And that's why we are here for this more further progressive combined learning. Thank you very much.